a minute, just let everyone come on board. Thank you very much for our panelists for participating, and thank you for all of our audience. Because we have a fairly large panel, I'll ask people if they have questions. There's a chat icon in the bottom of your screen that you can type in a question that I'd be able to ask on your behalf. Please do that because it's going to be difficult to turn on and off the microphones. Good morning, everyone. So I think that we'll start. It's a fairly cloudy Wednesday, May 6th, but hopefully will be a great, healthy day for all of us. This is one of the continuing sessions on looking at the pandemic of COVID-19 from different perspectives. And one of the areas, as people have been deployed and seeing patients, is tremendous teamwork that goes into every patient. This COVID-19 affects every organ, and it's really tremendous to see the expertise that we have in-house, national leaders in every area of medicine. And what we've been doing is picking the brains of many of them, and today hopefully will be the best program yet. We do have a lot of participants. I'm going to introduce them and then start with some of the people we don't hear that much about their organs and get their perspective because it's very important. We have Eric Neibart, who's our in-house infectious disease go-to person. Eric's an assistant professor of medicine and infectious disease, works very closely with us in cardiology. Dr. Jonathan Winston, thank you, Jonathan, is professor of medicine, division of nephrology, a renowned expert in the field. Dr. Glen Chun, assistant professor, division of pulmonary critical care and sleep medicine. One of, again, experts, been on the front line. We're very anxious to hear his perspective. Dr. Hooman, assistant professor of medicine, works very closely with our heart failure team, and recently became a national celebrity, being plastered all over the newspapers for something that we'll hear more about. Dr. Umesh Gidwani, our own director of cardiac intensive care unit, one of the foundations of the program. Thank you very much, Umesh. And Adel Bassily-Marcus, who is associate professor of medicine, of surgery and surgical critical care, who directs the surgical intensive care unit, with whom we've worked very, very closely, gave us one of the first great conferences on this. And Jeff Mechanick, who is a professor of metabolic disease, runs our cardiac rehab center, really one of the important people in cardiology, which has really transformed our perception of prevention. So again, thank you very much for being on board. What I wanted to do is to sort of go through each of the areas and give you a few questions, but I would like you to address each of you is your sort of organ, what the specific problems that you've seen, what are the challenges, and as we look forward, what's the perspective? So for Jonathan Winston, a few questions. Is there a distinct kidney disease, glomerulonephritis or glomerulopathy, related to COVID-19 in the kidney? We have a lot of issues about, is this a wet or dry disease? But we are seeing patients going into renal failure and requiring dialysis. Do they come off of that, and is this just a temporary issue? And issue of ACE and ARBs. And last but not least, kidney transplant, are they on hold? for the foreseeable future. Jonathan, thank you very much.
Oh my guy. Is this the medical resident that I have heard so much about? The star of PT, the king of Seroquel?
Can we please
Sorry, the Sultan of Seroquel.
mute microphone?
I'm an idiot. The Prince of PT, the Sultan of Seroquel.
Excuse me, can we please mute the microphone and your speaker? Thank you. Jonathan, are you there? I saw your face before.
Yeah,
Jonathan?
I'm here. That wasn't me, by the way.
Okay, thank you.
Thanks, and thanks for inviting me. There's definitely unique characteristics to COVID-associated kidney disease. I think that there's a whole spectrum of abnormalities. Most striking, and most of the cases that we share, is acute kidney injury, acute renal failure, syndromes. And a lot of our interest and our observations really comes from our experience in the critical care unit as consultants. And I also want to acknowledge Dr. Poor, who in many ways made so many important original hands-on observations of some of the abnormalities in clotting or thrombosis in these patients. And we saw similar issues during dialysis, but also in the pathogenic acute renal failure. So let me thank him again and congratulate him for his great work. But what we've seen in the ICU is a profound state of catabolic injury. Our acute renal failure patients look like a conventional tumor lysis syndrome or rhabdomyolysis. These are patients whose BUN shoots up from 20 to 100 in 3 days, CPK from 2 to 8 or 10 in the same period of time, marked hyperuricemia, hypophosphatemia, severe drops in serum albumin, and a lactate negative anion gap acidosis, all reminiscent of intracellular release of molecules similar to what you see in tumor lysis syndrome or rhabdomyolysis, but CPKs and aldolases are generally normal and there's no tumor. So these are highly, highly catabolic patients, and I can only assume that much of it is due to the cytokine storm. At the same time, there is thrombosis. If we dialyze patients, their circuits clot. We know about this now back and forth in the critical care unit and earlier on, strokes, cardiovascular disease. The question is microthrombi part of the pathogenesis of the acute renal failure? And I would say the jury is still out. Tissue diagnoses, when we do really autopsy studies, really show a predominance of ATN. There's newer studies that show that the virus can get into the kidney. So what pathogenic role that plays, it's unclear. And again, autopsy studies are almost for nephrologists a proof of principle, but everyone wants to get to these patients before we're looking at autopsy series. So the real question is earlier in the course of the disease, before patients really develop pneumonia, respiratory failure, overt thrombosis, is there a renal syndrome that is low grade and progressive? We don't have that information yet, but thankfully at places like Mount Sinai, we can get that information. But the most florid cases are massive acute renal failure requiring dialysis, severe tissue catabolism. Yes, patients can and do survive, but mortality rates are extremely high in the ICU and hopefully slowly improving. But our best chance at really making an impact is defining best practices and initiating them before there's sufficient tissue organ damage so that patients can avoid ICU, respirators, and the like.
Thank you, Jonathan, for those introductory comments. So we'll come back with some questions, particularly about what is the residual. Have you seen enough to understand what the residual damage is, and are we going to see an uptick in patients requiring, long-term dialysis or potential transplant after they get this injury? Can we go to Dr. Poor next? So again, as Dr. Winston said, I'm having you come on not only because of your expertise in pulmonary, but really to address some of the skill sets which you've shown in dealing with hypercoagulability, the macro and micro thrombi that we've seen. Can you address some of those issues, Dr. Poor? And again, thank you very much for coming on.
About COVID. Thanks.
Yeah, it's, this condition is extraordinarily confusing. As been kind of discussed, the respiratory failure that these patients develop, is pretty profound with severe gas exchange abnormalities, with a combination of, shunting where you have areas of blood bypassing ventilated lung, and then also areas of dead space ventilation. But notably, these patients have very compliant lungs, particularly early on in the disease. And when we see that combination of compliant lungs, gas exchange abnormalities, pulmonary vascular disease is the thing that comes to the top, and specifically embolism. And so, as Dr. Winston mentioned, and there has been, a lot of clotting phenomenon seen with dialysis catheters, with very high rates of VTE that are noticed, and quite frankly, we're not even testing as much as we normally would be. And so even despite that, we're seeing thrombi in areas of the body that we normally don't even see. And with kind of anecdotal evidence of thrombi from giving thrombolysis, and also from, unfortunately, autopsy results. Part of the problem with this disease is that it's not as clear cut as just endothelial damage and thrombi. There clearly is heterogeneity to this. And a lot of it may have to do with the time course of the disease. Specifically, we're seeing a lot of patients that come in respiratory failure. And we used to intubate them very early on, and they would have a particular phenotype, specifically the one with the compliant lungs and gas exchange abnormalities. However, with time, specifically ventilator-induced lung injury, and then also a form of lung injury known as SILI, self-induced lung injury, where patients take deep breaths and then cause lung stretch and damage. They can induce a lung injury very reminiscent of ARDS, and the more classic form of ARDS. And that dichotomy makes it very difficult in terms of figuring out what the problem is. Other disorders like ARDS and sepsis have thrombi associated with them, but it doesn't seem like those conditions really are a driver of disease. Whereas now it looks like at least the thrombosis associated with this condition may be playing a significant role. And the time is now to determine whether empiric anticoagulation early on and even thrombolysis in more severe cases may actually affect outcomes in a positive way.
You want to just tell us about the incident that you've seen potentially underestimated of pulmonary emboli, large and small, and your thoughts. I know there's a lot that cardiology has been doing in leadership regarding antithrombotic, anticoagulant. From your perspective, what is the best regimen to use, both for in-house patients as well as potentially patients who haven't been admitted, and then following through on those patients who get discharged?
Yeah, I mean, it's an excellent question, and it's hard to determine what the optimal strategy really is. I think part of it is the sicker you are, and if you have signs of respiratory failure, I think it is prudent to be on anticoagulation and on therapy coagulation. It's more difficult when you're not as sick and you don't necessarily have high D-dimers, and you're kind of assessing risk of developing it, or whether the process is thrombotic at all. Some kind of graded anticoagulation strategy as such that has been created at our institution with our guidelines, I think is good right now, with kind of looking back and seeing, are there lower risk patients that could better be split up and giving less anticoagulation to a subgroup and more anticoagulation to another subgroup. The other problem that we've seen there have been a number of patients that have been discharged home from the hospital with COVID, who then come back with, large PEs. There's going to need, this is clearly a thrombotic state, and patients should be on some kind of tail of anticoagulation when they are discharged. There are patients at home who have COVID who are being managed at home, and then their ultimate presentation is, a large PE with infarct. So determining who really is at the highest risk when they're not in the ICU to give them full dose anticoagulation is going to be a challenge, and for future studies to determine that.
Thank you very much, Dr. Poor. Jeff Mechanick, you see most of the patients in the hospital every day. I don't know how you do that, but I specifically would like you to address a couple of the issues that we don't really think about. Patients who have diabetes and the potential flare that can occur. Hello, I'm on the phone. That's Dr. Sharma. The potential flare that can occur. Also, we've been giving these large doses of steroids, how that affects the metabolism. Also, the nutrition. A lot of these patients are very malnourished, either because of inability to eat, or they're intubated, or they have diarrhea. So if you can address the diabetes, are there other endocrine abnormalities? Have you seen thyroiditis, any problem with adrenal gland? And then the issue of nutrition. Jeff?
Sure. Thank you, Marty. Can you hear me okay?
Yes, great. Thank you.
All right, terrific. So let me just provide some context for the questions. The questions are primarily centered on the management in the acute phase of this COVID syndrome, but the context is a COVID-related cardiometabolic syndrome. If we look at the way in which we put that diagnosis together, we have experience, epidemiologic data, and mechanistic information. So from experience, I think everybody on the call was struck very impressively at the beginning of the pandemic as Mount Sinai became involved, that patients were coming in, you look at their BMIs and they were in the high 30s, 40s, even 50s, and with very, very severe insulin resistance, requiring huge amounts of insulin, and also developing this syndromic presentation, not only with hypertension then being a predictor for outcome, but this prothrombotic state, the encephalopathy, the acute kidney injury that Dr. Winston was speaking about, and then later on the hyperphosphatemia, the hypocalcemia, and all related to this cytokine storm. So how do we put this all together to provide context for what's happening in the hospital? So first, if you look at the experience, I just went through that. Epidemiologically, if you look at China, Italy, Spain, France, and the US, you see that there is an increased association of obesity around 40, 45%, diabetes 38 to say 40%, and hypertension about 50% among those hospitalized. And when you look at mortality, in the US and Italy, hypertension, about 70% of the patients who had mortality had hypertension, 50% or so with diabetes, and maybe 80%, 88% in the US with obesity. A lot of these data are confounded by differences in definition, obviously, looking at Asia. And then mechanism, what we've done here is we've built this COVID-related cardiometabolic syndrome, which starts with social determinants of health, and you read about that with the differences in ethnicities and socioeconomic classes and disparities in access to healthcare. Social determinants of health and biological determinants of health, creating this unhealthy lifestyle of the patient in the pre-COVID phase. Then they develop this abnormal adiposity, pericardial, epicardial fat, fatty liver, fatty kidney, peripancreatic fat, visceral fat. This creates an inflammatory state, a state of insulin resistance, beta cell enfeeblement, and you get hyperglycemia. Now COVID comes along, and you have the spike protein going through ACE2, which may be overexpressed in a lot of these patients already at risk from this cardiometabolic syndrome. And now you have a cytokine storm, an aggravation of an amplification of the inflammatory and prothrombotic basis. And you have this awful picture that we all see in the ICU. So now we're faced with the acute management, and we are confronted with challenges wherein we would have ordinarily managed patients with insulin drips because of resource shortages. And also the pragmatic aspect of not having our healthcare professionals constantly going into the room and checking sugars every hour on a drip. We needed to come up with protocols where we were managing these patients with sub-Q insulin, and other centers around the country and the world have started to adopt these protocols, where we're using a stacking of Q6 NPH and then incidental correction with Lispro whenever someone's in the room. We had shortages of enteral pumps, so we had to start transitioning to bolus tube feeds. We want to intervene early to prevent a malnutrition standpoint, but we want to avoid enteral nutrition in this hyperacute setting with severe insulin resistance because of the glucotoxicity. So we were actually permissively underfeeding at a very early stage. What's interesting is those of you on the call can probably reflect back. The way we're managing now is so much easier in a way compared to how we were scrambling early on and adapting multiple concurrent protocols. As far as the steroids go, and I'll leave this also to Dr. Neibart to talk about steroids, but early steroids really aggravate the hyperglycemia, as you would imagine, but they also quell the hypercytokinemia and the inflammatory state. We were able to adapt to this just by liberalizing the blood glucose target. As far as nutrition goes, it's not so much in the acute phase, but now we're entering into this post-viral syndrome, this post-COVID syndrome. Patients have encephalopathy, they have chronic kidney disease. Now they have breakdown of the muscle mass and a sarcopenia that Dr. Winston was speaking of. And now we want to come in with the high protein enteral nutrition and meet the calories. Let me close with one last thing. We're collecting data now on new indications for parenteral nutrition in COVID. One of them was proning. We were finding that with proning, a lot of the intensivists were holding the enteral feeds, exposing patients to undernutrition. Otherwise, the non-rebreather masks and the BiPAPs were precluding intestinal access, and that was another indication. And I'll close with our experience using IV chromium, which seems to be working in maybe about 60 to 80% of patients in resensitizing the insulin receptors, and that represented another indication for parenteral nutrition. Thanks.
Thank you very much. So we'll come back. Can I ask Eric Neibart, I'm just going to give you a few flash questions and just say yes, no, maybe. So we'll go through medications. Hydrochloroquine, a winner or not?
A big loser.
Okay. Azithromax?
A bigger loser.
Okay. Steroids?
I'm going to be a vociferous advocate for early use. Anybody with 4 liters of oxygen requirement or more.
Plasma antibodies?
Nobody knows.
Tocilizumab?
There's a lot of people that have gotten it. There's almost no data reported. I'm aware, all the data that I've seen reported is, 3 cases, 5 cases, 6 cases. Certainly it appears, at least historically wise, plasma therapy needs to be given very early in the course to have merit.
Tocilizumab?
Very focused use. It needs to be, it's not going to have use for the patient that's already been ventilated. It's certainly for that patient with that tornado of a cytokine storm. Interesting, there's a paper came out yesterday looking at on how hyperglycemia dramatically decreases the efficacy of tocilizumab.
People have been getting vitamin C and zinc.
Yeah, I don't think that would have protected 19,000 people that have died in New York City.
Hey, can you address something that we see is secondary infections? People have been looking at procalcitonin, or people looking at the white count, and say, we look at the X-ray. How do we determine that there's a secondary bacterial infection that requires treatment? Because a lot of the patients have been getting, antibiotics.
Actually, a study came out yesterday or today looking at blood culture data for secondary infection, and it turns out that COVID patients actually have less positive blood cultures than other ICU patients, and even a third of the positive blood cultures in them are skin organisms and likely contaminants. Procalcitonin is not a distinguisher here between a secondary infection. Procalcitonin elevation is actually a marker of the of the huge cytokine storm and a negative prognostic feature.
Thank you. We're going to come back. Thank you very much. Any general comments that you want to make about treatments that you see now, or the future treatments coming down the line?
I think one shift that we've all had is in the beginning, we looked at markers, or we looked at oxygen requirements. We say, oh, this patient isn't that bad, and we're doing supportive care. And a lot of the studies and things were started on patients entering the ICU or the day before. And I think the paradigm really needs to be moved up to almost presentation.
Thank you very much. I'm saving Adel for general comments at the end, because he's been there every single day in the front line. So I want his perspective after I have Umesh and Glen. Are you doing a tag team together, Umesh? Dr. Gidwani, are you with me? You have to turn your microphone on.
Yeah.
Okay.
So let me just lay the foundational groundwork of what we think is going on, and then Glen and I spoke, and Glen has some very important inputs regarding the type of ARDS that we've been seeing. Now, as Dr. Poor mentioned, we are seeing a wide, broad heterogeneity of presentations. And as we enter the 8th and the 9th week of this disease, we have several things that we wish we knew at the 1st and 2nd week. Initially, when we were presented with this syndrome, we tried to niche it into something that we had seen, something that we were comfortable with, a paradigm that we could follow for the management. I'm going to share my screen now, because we've come up, with
Umesh, your microphone, you're going in and out. Please maybe adjust your microphone. Thank you.
I think there is background noise. Somebody, if you could please mute. Is this better?
Yes, thank you.
Okay.
Can we please have people mute their microphones except for the speaker? Thank you.
You'll find he has a funny name, so you find the MRI in the casket.
Dr. Dengus, we don't, we hear you. Please mute your microphone. Thank you.
So, as we were saying, we've come up with a conceptual framework which we can now explore to see what are the intersection of what we are seeing. And I postulate that this COVID inflammatory response syndrome, or SIRS, is very different from the other common severe inflammatory response syndromes, such as those seen in the ICU. And it's very important to realize and recognize this, because we have over time, these 6 or 8 weeks, people in the front lines have learned from some of our mistakes going down a certain path. So let's just review some of these inflammatory syndromes. So the first one that we were conditioned to was the classic SIRS model where, you know, a urinary tract in pneumonia leads to an ARDS. You give them fluids and antibiotics, and in a few days they get better and they get extubated. You know, they show signs of improved oxygenation and spontaneous breathing. We extubate them and we move them along. And of course, over time, we've seen that depending on, you know, what study you look at and what the inciting trigger is, and the time at which you catch it, you've had a mortality of somewhere between 30 and 50%. The other problem that the other trap that we felt, you know, we stumbled across was the fact that everyone was calling this the cytokine release syndrome and the cytokine storm. Some people have also referred to it as. And the problem with that is, as intensivists, we are accustomed to, in the pre-COVID era, singular type of CRS, or at least severe CRS, that is grade 3 or 4, that is associated with hematologic malignancies. Initially, those that were treated with monoclonal antibodies when they come around, and then later with haploidentical allogeneic transplantation, and latest with the CAR T cell therapy. So we have well-established protocols. We recognize these CAR T cell therapies, and the IL-6 inhibitors and sometimes the IL-1 inhibitors actually work very well, so that the mortality is typically less than 30–40%, even in the grades 3 and 4 CRS. And so when we started treating people like this, I'm not sure that we found you know, the same response to the tocilizumab or the sarilumab. Some hematologists, oncologists believe that maybe that we are using this too late, but there are so many other differences from the cytokine release syndrome or the CRS that is associated with hematologic malignancies that do not fit into this paradigm. Now, HLH, as many of you know, is a life-threatening excessive immune activation, and very, you know, it resembles this syndrome very closely. At one of the earlier talks, I had shown you a slide where a lot of the HLH type symptoms were present in these CRS patients. And we said that if we calculate the H scores, which are how you grade the HLH, you will find that the H scores are so high that you would call this HLH if you did not know that this was associated with COVID. Again, the problem with that is that there is a well-established management protocol that is different than anything else we are using. For HLH, the 1994 guidelines use VP16 and steroids, and if it doesn't come under control, add cyclosporin. And the 2012 guidelines ask for a call for steroids to be used even earlier, even before the presentation of severe HLH. Now, coming back to SIRS, why is this important? This is important because in this severe CRS, the one that I am postulating is different from everything else. This is a prolonged illness. This is not something that goes away in a short period of time, such as SIRS, or an intermediate period of time, such as CRS or HLH. This lasts and lasts and lasts. We have people here for 4 weeks, 5 weeks, and 6 weeks, and it seems that there is an ongoing viremia that continues to stimulate cytokine release. And this is seen in the undulating pattern of the inflammatory markers. D-dimers go up and down, ferritin goes up and down, and all these others go up and down, so that it suggests that there is ongoing viremia. And in fact, in a very interesting autopsy studies, those that had persistent viral shedding were associated with the highest mortality and the longest duration of illness. And so it seems that this is very different. This presents a pitfall, because when we, as conditioned by SIRS intensivists, see this initial improvement, It's day 4, 5, 6, and the patient gets better. The oxygenation improves somewhat. There is spontaneous breathing. We extubate these people. But this ongoing viremic insult causes the patient to huff and puff for 2, 3, 4, 5 weeks and get re-intubated. And this worsens the injury because for these 3 or 4 or 5 weeks, they are not stable. They are getting what is called SILI or PSILI, that is patient self-induced lung injury, which is a mechanism elucidated by the Europeans about 2, 3 years ago, which suggests that this negative intrathoracic pressure and this work of breathing expands and collapses alveoli, and these already damaged gas exchange units get further damaged just by the patient breathing, because there is an excessive and abnormal breathing that we see. And so it's important to realize that this is not a SIRS type syndrome, that you do not extubate them at day 3, 4, and 5, because they're not going to quote unquote fly. They are going to continue to damage their lungs by the mechanism called SILI that Dr. Kaur has talked about a few minutes ago. So
that happened the first time.
Can you see my, am I sharing my slides with you?
Not yet.
Okay. So this was okay, share. And so this was the spectrum of diseases that I talked about. Sorry, while I was talking, I should have had this thing up, which is what I'll share this later. So now we talk about what are some of the similarities and differences between this, my postulated COVID inflammatory response syndrome and some of the other inflammatory response syndrome. Clearly, all of them at the center of it all have some kind of multi-system inflammation that affects, now again, one more under-recognized system that affects not only the respiratory, renal, circulatory systems, but also importantly, CNS. Almost all of these patients have an encephalopathy and take a long time to wake up. We sent patients to the LTAC, and I call the LTACs to find out how they're doing, and they've come off the vent, but they are still not fully awake, alert, and oriented. And this is a mechanism that's reported and will be elucidated with time. Now, the important differences, SIRS, that occurs, the COVID inflammatory response syndrome, has as a predominant trigger a thrombotic syndrome that others have talked about. The ventilatory strategy has to be modified, and this is what Dr. Chun will talk about. And the therapy is still unclear. You know, maybe we should be using, obviously, antithrombotics and steroids early. Do the...
And people, please shut their microphones if they're not speaking. Thank you. Sorry, Umesh.
You know, are IL-6 inhibitors going to work or not? And one thing is clear, this duration is longer than anything we have seen before. And I predict that this is going to be a problem where we have these chronically critically ill who are neither improving fast enough that we can discharge them, nor succumbing to their illness because we have such good supportive mechanisms. And therefore we are opening, let's say, 100 beds or more in Beth Israel to house these patients. We already talked about the classic SIRS. They have the classic ARDS, which is important to distinguish from the KERS ARDS. In HLH, we know that the therapies are extremely different, steroids, VP16, cyclosporin. And in the oncologic CRS, we know that that is a different animal. It responds well to tocilizumab and some of the other new anti-IL-1 and anti-IL-6 antagonists. And again, the duration is limited if they live. Now, there's one other syndrome that I want to talk about. This is Jaden Hardawar of Queens, age 8. And it was a little ill with the flu-like syndrome. And then over a period of hours, his older brother is a Boy Scout, age 14. And this kid suddenly becomes cyanotic and passes out. And his brother does CPR, calls 911, takes the patient to Cohen's Children's Hospital of the LIJ system. And they find that this kid has a combination of a Kawasaki-like illness with COVID positive and a toxic shock kind of syndrome with diffuse rash. Now, this was first reported in BMJ in late April, around 24th, 25th April, where they talked about an overlapping, a syndrome of overlapping features of toxic shock and atypical Kawasaki with blood parameters consistent with severe COVID, that is. Rupa ji, Rupa, can you silence your microphone, please, on mute? Thank you. And then on the 1st or the 2nd of May, Veena Jones from Stanford, in a pre-publication of Pediatric Hospitalist, presented the first such case in the US, where she talked about a 6-month-old infant admitted and diagnosed with classic Kawasaki disease and was positive for COVID syndrome in the setting of fever, but minimal respiratory symptoms. And just on the 4th of May, I think, which is 2 days ago, the NYC DOH put out a advisory that they screened people between April 29 and May 3rd and found 15 patients aged 2 to 15 with a syndrome consistent of what they call PMIS, or Pediatric Multi-Inflammatory Syndrome, which these kids had either typical Kawasaki disease or incomplete Kawasaki disease and or shock with fever. More than half had rash, abdominal pain, vomiting, diarrhea, and most were known to be COVID positive, either PCR or in those who were PCR negative, the antibodies came back positive. And so it seems like this is very different inflammatory syndrome. So this kind of almost confirmed my suspicion that this COVID inflammatory response syndrome is extremely difficult from any of the previously known severe multisystem inflammatory syndromes. And I suspect that a lot more will be found out, both in adult and pediatric disease, with a unique COVID-specific inflammatory response syndrome. Thank you.
Thank you very much. Glenn, are you doing, Glenn, Chun?
I'm here.
You're going to give us some comments on what you're seeing, following up with, how is this different than ARDS? Is this a wet lung or a dry lung? That's a major concern. And are you seeing the pulmonary lesions resolve, or are they leaving fibrosis behind? And are patients going to have a permanent disability? And
so it's all great questions. It's all great questions. I think with regards to ARDS, I mean, I think this was the biggest issue that we had from the onset of the pandemic, essentially. We tried to extrapolate the data that we've accumulated over the last 20 to 30 years with regards to mortality benefits and ARDS treatments using things like proning, steroids, low tidal volumes, high PEEP strategies, and tried to extrapolate that out. And all the sort of established gold standard treatments that we use for ARDS, we tried to extrapolate onto these particular patients. And I think that was not necessarily the right strategy. For example, obviously we talked about low tidal volume. I think everybody's in agreement that that's to a certain degree probably the gold standard. The high PEEPs is very debatable. We have these discussions, these theoretical phenotypes, essentially a type L and a type H, essentially looking at low elastance levels with high compliance and high elastance levels with low compliance, and how rigid and compliant the lungs are. And I think this is all mentioned before. You know, at this point, what we do know is what's safe is proning. We don't know if all the other strategies that we've used for many years with regards to typical ARDS actually has an actual benefit or mortality benefit for these patients. With regards to you know, long-term effects and X-rays, I mean, those are really good questions that we don't have the answers to yet. Most patients who are discharged from the hospital, they continue to have infiltrates. That's not uncommon for typical pneumonias and ARDSs, obviously we see that these infiltrates and airspace opacities can persist for weeks, if not months, post-hospitalizations, post-ARDS, post-inflammatory states. And we don't know. I mean, prospectively speaking, we're going to have to look into this. This is going to be a huge area of follow-up research, clinical experience, and clinical focus going forward in this post-COVID era. And we don't know what the long-term effects are going to be. The degree of fibrosis is very unclear. It's interesting because as Hooman had mentioned before, we are seeing these theorized type L and type H's, and that may be two separate phenotypes, or it may just be a progression of the disease process. But I think everybody who's seen these patients in the ICU can definitely agree upon the one fact that despite how severe their gas exchange is and how poor their oxygenation is, what we do know is that they have extremely, paradoxically, very, very compliant lungs. Their plateau pressures are very, very low, and but they're just incredibly difficult to oxygenate. And the strategies that we've used actually haven't been all that helpful.
Can you address a couple of quick points? So because of that, the use of PEEP should be restricted, question mark. Additionally, looking at the lung pathology, one of the things one of the markers are O2 saturation, but one of the things also is increased respiratory rate. It looks like patients are taking shorter, quicker breaths, which then may lead to further, mismatch and further hypoxia. Have you been addressing some of these issues?
We have. With regards to the mismatch, I think that there definitely is some underlying pathophysiologic process that's causing this. You see a lot of tachypnea. A lot of these patients require high degrees of sedation, and vast majority of these patients are being paralyzed at some degree, and it's been very difficult to actually come off of the neuromuscular blockade agents because of how tachypnic and desynchronous they become. And obviously from our critical care standpoint, we get concerned about delirium and critical care weakness and myopathy that's associated with prolonged neuromuscular blockade usage.
Thank you. We'll come back with some questions. Adel, Bassily-Marcus is on the front line since day one. He is sort of vice chair of critical care. He has been running the surgical intensive care unit, which is now decovidized. But I would go to him virtually every single day. And he certainly has a perspective on how this disease has evolved. Can you give us some insight to how the disease has changed over the 8 weeks? And I think that Umesh and some of the other people were talking about what you told me about the other day, that you have patients who are intubated, then extubated, go to the floor, and then have catastrophic events. So give us your perspective on the evolution of this disease. There was a report that this virus has mutated. Has that led to a change in what we've seen compared to other countries? And then where do we go forward? Dr. Marcus, Bassily, thank you so much for everything you've done with your leadership and guidelines. Please, thank you.
Thank you, Marty, for this kind introduction. And you have been with us every single day. It's really amazing how everybody is really joining shoulder to shoulder in facing this unprecedented disease that's impacting each one of us. Each one of the panelists and the speakers have similar experience, and we're all on the front lines and having a very similar observation, and I'm happy that we are all seeing the same thing. Unfortunately, what to do about it is the challenging part. I can tell you how much overlap we have. We almost agree identically on everything. I'm going to share a slide that I prepared. Not speakers gonna address these topics, but quickly, it is like Hooman mentioned. You guys see my slides?
Yes, we can. Thank you.
it is unusual disease. This is not our typical ARDS. This is not our typical pneumonia. This is not our usual cytokine release, as Umesh mentioned. It's very different. And one of the distinguishing differences is patients are profoundly hypoxic. They tolerate this hypoxia for long, till no longer they can tolerate it. And when they get to that point and requiring mechanical ventilation, they are very sick and remain profoundly hypoxic, despite all the maneuvers that Glen mentioned and Hooman mentioned about what do we do, whether we prone them or not. Glen mentioned about and as well as Hooman, the H and L types. Obviously, we typically, the right picture, it's what we see in ARDS. These are your stiff lung, wet and heavy, and is not compliant. It's not easily to inflate. And these are the lungs that we know from the last 20 years that we need to use low tidal volume, proning early, and try to shift these fluids from the bases to the top. But we also know that there is, early on in the disease, the lung is the L type, the low everything, low VQ mismatch, low lung weight, and low recruitability. And these are commonly seen early on in COVID. And it's unclear whether proning, it doesn't look like proning would have an impact on that. Obviously, it's a spectrum between the two. We may see the patient here, we may see the patient on the left, and then in between transitioning into that. And clearly, not all our intervention work. I think it's not like the virus has changed or the disease has changed. I think it's more our understanding now from the collective observation is more solidified. We're seeing commonly and we're sharing experiences and we observe and we try doing different things, hoping something will work. Obviously in the controlled trials, we'll have the verdict on that. But in the meantime, the observation continue. We see micro and macro thrombosis, as Hooman mentioned. I want to share with you also, I've seen arterial thrombosis. We had a patient with COVID pneumonia, and incidentally, we found bilateral renal artery thrombosis requiring thrombolysis and stenting, and acute kidney injury that was not expected. Are we missing out on these thrombosis or not? Do we need to, in addition of anticoagulation, identify the group of patients who also need antiplatelet therapy? And that's, again, needs to be in a studied fashion. Dr. Winston mentioned the acute kidney injury. I give him a lot of credit, and their department have been extremely busy. And I never asked so many dialysis requests in my ICU. Almost 90% of our patients have acute kidney injury, if not more. Very few would say, okay, are we missing acute kidney injury when we see normal renal function? And we say, this is odd, this is unusual. What's special about this patient? And it's still puzzling to us who gets it and who doesn't, but it seemed to be extremely common, related to microthrombosis based on autopsy results or related to other factors that's not clear. I want to point out to the delirium effect and the encephalopathy that goes on and gets very prolonged. There is so many literature on it. This is just a quick summary in a New England Journal of Medicine describing about 84% of the patients who have COVID have neurological signs, and that's profound, and we see that commonly and lingers for a long time. And they also pointed out to a new syndrome which never heard before, which is dysexecutive syndrome, which is inattention and disorientation or poorly organized movement in response to commands. These are the non-intubated patient, the one who did not get sedation. These are the ones who cannot blame it on ICU delirium that we commonly see, this even before they get to that point. And it struck me that it persists. Even young patients after extubation never got prolonged benzodiazepine, which is a major risk factor for delirium, and yet they not behaving themselves. Something unusual about their affect, their response, their attention, and they may not be talking for some time and start ease up. A couple of other observations: the high fever, and something also unexplainable. With this high fever of 41 and 42, you get profound hypotension, very refractory to pressors till really very high doses. And as the patient cools off, whether with intervention, cooling blankets, and IV medication that I don't think help, and even hypothermia, the shock resolves. It seemed that's just a reflection of the cytokine release and the vasodilatory effect of that. This is interesting also observation. I want to point out a couple of observations. Male patients, and Umesh touched on the prolonged course and its rocky course. Patient gets better, and then not because we are doing a specific intervention, and then they get worse, and then they get better again, and then they get worse. And every third day I feel I'm back to square one again. That happens, and it's still not clear why oxygenation improves. And sometimes the patient oxygenation is not the factor, and just become hypoxic, hypotensive again. And the point that Dr. Goldman mentioned about unexplained death is still puzzling. We had young patients who oxygenation is doing okay, whether weaned or weaning, with tracheostomy or extubated, and suddenly goes in cardiac arrest. Unfortunately, we witnessed too many of these. It's still puzzling. Is it arrhythmia? We're trying to analyze, and we get a lot of help from Dr. Reddy and Dr. Goldman. Try to see, is this arrhythmia? Is this viral myocarditis? PE, this is the first thing that we rule out. We do a bedside echo, and these are not your classic sudden PE and cardiogenic shock or obstructive shock. There's something else, and it's unfortunate. We lost 2 patients in their early 30s, at least in my observation, and it's still not clear why. I shared a lot of information. It's still puzzling to a lot of us. I know more, and we all know more than 6-7 weeks when we started, but we're still learning about this disease.
Thank you, Adel. Should patients who get extubated be monitored for a longer period of time then, with cardiac monitoring for closer observation based on what you saw?
Yeah, and these patients, even after their ICU day, they 2 of them were in step-down units, and they were. I don't know if the monitoring is the issue or something else. There is a limit to how much you're gonna monitor somebody who looks stable, and suddenly who you can't predict who's gonna decompensate, since we don't have a clear pathophysiological mechanism.
Thank you very much, and for everything you've done. Just looking forward, Eric, can I ask you a few questions about the antibody testing? So if somebody, Eric, are you still there? Eric? Dr. Neibart?
I'm here.
So what I wanted to ask you is about the antibody testing. Are we putting over-reliance if somebody tests antibody positive? Do we know what that means regarding their susceptibility? And if somebody still has antigen positive and they're antibody positive, are they still contagious? Or does that mean that it's non-viable virus? Or we don't know. So give us some insight into the antibody testing that we're all doing, and we're giving it back as plasma. We haven't heard anything yet. Early reports would have come out already, front page of the New York Times if it was a big smash. So tell us about antibodies, tell us about residual antigen that people have, and the sustained course that people have 5-6 weeks out, they're still sick with COVID.
Yeah, we'll start with the antigen first. I think, we've all seen people that have these sort of on and off antigens or prolonged antigens. I think the feeling is that for the most part, that's extracellular degenerating viral particles, and a PCR test picks that up. The antibody testing, I think the duration of a positive antibody, if it's a neutralizing antibody or a protective antibody, is really not known. I think really right now the antibody testing is most useful as an epidemiological tool. And I think that's sort of pretty much where we're at. I think, you know, people were sort of talking about a couple weeks ago getting antibody testing, and that would be your passport to freedom, whether it's going to work, travel, or whatnot. That's certainly gone by the wayside. And we certainly see that there's a lot of people that take a long time to develop an antibody. I think you got to be very careful about whose test you use. You know, I would certainly stick with major providers and whose testing that I was actually using. I think, you know, at least with other diseases, you know, I mean, being antigen positive and then getting a positive antibody is sort of reflective, I think, of you know, the end of a disease and improving immune response to eliminating it. But I think most of this testing right now is an epidemiologic tool more than what we can say it means for an individual patient.
Thank you. So 2 last questions. You know, I get so many calls from patients. When can they go back with their families? They've self-quarantined, they had the disease, they're antibody positive now. Does that mean that they can re-enter the world? They're 2 weeks symptom-free. Do they go back with their families now?
I think there's different answers from different people. Certainly somebody that's symptom-free and no fever for 3 days, you know, we've been talking about going back to work. Certainly at 2 weeks and being antibody positive, I would tell them they could see their family, and it's what I've observed, you know, told patients.
And what about people who've been working in the hospital, workers or, you know, non-medical people, haven't been infected, have no antibodies? Are they wearing masks forever now?
Well, I think right now the policy is going to be masks for patient contact. There is some data of finding aerosol virus in public spaces and medical staff offices also. The bigger debate is whether you use a surgical mask or an N95, and that's sort of a ongoing debate now. Actually, the Infectious Disease Society sort of took a punt and they recommended either or.
I just, you know, we've run out of time. We certainly haven't run out of tremendous amount of questions that we have for this fantastic panel. What I do want to point out to everyone is that this is a team sport, that every person that we've had on the panel has really been working very closely together and become good friends, working together on the same patients, collaborating to really get their patient the best possible medical care. We sometimes take for granted, certainly in cardiology, the luminaries that we have. And today sort of highlighted the tremendous luminaries we have across the board in medicine, particularly in critical care. I want to thank each of our panelists. I apologize for not having more time for this panel. We'll certainly have another part of this with the same panelists because we just have to address all the questions that came up. So again, wishing everyone a wonderful day. Thank you all of the panelists and all of the people who have been listening at home, making this Zoom conference a success. Have a great day. We'll see each other tomorrow. Thank you.
Yeah.